Hi all. Good afternoon. Am I audible?
Yes, ma'am.
Hi all.
Good
So
morning. Good afternoon,
today
ma'am.
we are going to talk about delirium. And first of all, I would like to welcome you all for the next session. And a very warm welcome for you, sir, Tony. Tony, sir. And thank you to be with us. Today our facilitator is not there, so I am going to introduce our faculty. Just a second. So, Dr. Tony started his career as a casualty medical officer at KS Hedge Medical College, and then he worked as a medical officer at CHC Kanyakulangara, and later he gained experience as junior resident in Department of Rheumatology at Believers Medical College. Since January 2024, he has been serving as a palliative care physician at Pallium, India. Sir, welcome you, sir, and over to you.
Thank you very much. So, can we start the session? Am I audible?
Yes, sir, you are.
Yeah, thank you. I'll share my screen. Just one moment. Is it visible?
Yes, sir.
Yeah, thank you. So, good morning, everyone. And can any one of you please volunteer and read this for us?
Yes, sir. Case 1. Mrs. Y, a 72-year-old woman with advanced cancer, was admitted to the palliative care unit for symptom management. She was previously alert and oriented, but suddenly became restless, started mumbling incoherently, and had difficulty recognizing her daughter. She seemed frightened, kept trying to get out of bed, and was convinced there were strangers in the room. Her symptoms fluctuated throughout the day. Sometimes she appeared calm, but by evening she was more agitated again.
So, what are the key things that came to your mind after reading this? What were the symptoms the patient was having?
So, hallucination,
Hallucination, okay. What else?
sensory hallucination,
Hmm. There was restlessness. She was trying to talk something. She was mumbling incoherently. The whatever she was trying to convey, but we can't recognize what it was. And she is not even oriented also. See, she had difficulty recognizing her daughter. So at least 3 to 4 points came to your mind. That's very good. So now this is also a similar case. Mr. X, a 65-year-old man diagnosed with carcinoma of lungs. He's on morphine for his pain. His caregivers reports to you that the patient frequently talks irrelevantly, but at times he is very clear. They also said that the patient is sleeping more in morning hours compared to night. And these problems developed just 3 days back. So a cancer patient on morphine for his pain. What is his current symptom? Irrelevant talk. Is it continuous? Is that symptom prolonging? No. At times is normal also. There are times there are lucid intervals. And what is the next point? He's sleeping more in the morning hours compared to night. And these problems just developed 3 days back. These problems developed acutely. So what is the diagnosis here in these two cases? This is called delirium. And what is the definition for how can you define delirium? Or before going to introduction or the definition for delirium, this delirium is considered as the most common psychiatric morbidity or disease seen in patients with acute medical illness. Delirium is often under-recognized. When a disease is under-recognized, it is often under-treated also. So this word delirium comes from a Latin word called delirare, which simply means to go off the track, to go away from the normal. So now we will define delirium. So as per DSM-5 criteria, delirium is defined as a disturbance in attention and awareness. The patient doesn't pay much attention to whatever is happening nearby. He is not aware of the surrounding. And this develops acutely. This is acute in onset. That is, it can be hours to days. And it tends to fluctuate. And at least one additional disturbance in cognition, like orientation, speaking, memory impairment, anything can be there. And the above mentioned symptom should not be better explained by a existing dementia. You all may be familiar with dementia. So, and there should be an evidence of an underlying organic etiology or etiologies. So basically, what is delirium? Delirium is a global cerebral dysfunction, something wrong with our brain, causing disturbance in attention and awareness. And this should be acute in onset and tends to fluctuate. Okay, so these are the key points to diagnose delirium. And why is it important to study about delirium or diagnose delirium? How common is delirium? When you consider a normal hospital setup, a normal hospital IP, 10 to 30% of the patients are prone to develop delirium. That means in a 100-bed hospital, around 30 people are likely to develop delirium. And seriously, in ICU, the numbers are even high, 20 to 50%. So if it is a 10-bedded ICU, 10 patients in ICU, out of the 10 patients, 5 are prone to develop delirium. Is that a small number? Obviously, no. And delirium is also seen in around 88% of patients nearing end of life. So I think by this slide, you might understand how common or how important delirium is. Why is it important to recognize? In the previous slide, you understood how common is delirium. In the first two pages, we mentioned about two patients. In case one, the patient was restless, started mumbling incoherently, had difficulty recognizing daughter. She keeps trying to get out of bed. What and all can happen to such a patient? Will the treating doctor or the treating team will be confident to discharge the patient in such a condition? No. What else can occur? If such situation prolongs, there can be more falls. There can be more incidents of falls. Am I right?
Yes, sir.
So when the patient develops delirium, there is a higher mortality, which is twice than that of the matched controls. There can be increased incidence of falls. When such situations occur, the hospital stay will get prolonged. When the hospital stay gets prolonged, what happens? The cost, the healthcare cost, the amount of money the caregivers or the patient have to pay will increase. And this overall everything, overall healthcare cost, seeing their loved ones suffering like this, everything will be traumatizing for the caregivers. And coming to pathophysiology, how does delirium occur? And unfortunately, the exact pathophysiology is very poorly understood, but there are multiple hypotheses, such as neuroinflammatory, neuronal aging hypothesis, oxidative stress, and neurotransmitter deficiency hypothesis, out of which this neurotransmitter deficiency hypothesis holds a place. It is believed that deficiency of acetylcholine and dopamine are some of the neurotransmitters in our brain. And it is believed that deficiency of acetylcholine and excess of dopamine is the key reason behind delirium. So what is it? Decreasing levels of acetylcholine and increasing levels of dopamine. And this is simply a picture showing different etiologies for delirium. Like you can see this later. To remember the causes for delirium or etiology for delirium, there's a small mnemonic like DELIRIUM, where each stands for different things. D stands for drugs. There are different drugs that cause delirium. Can someone use the chat box and tell me what are the common drugs that can cause delirium? What are the common drugs that can cause delirium? Okay, opioids are there. Some sedatives, okay, benzodiazepines are there. Yeah, very good, very good. Thank you for the response. So there are certain medicines that cause delirium, like as you mentioned, sedatives are there, like benzodiazepines, barbiturates, antihistamines, certain anticholinergic drugs, oxybutynin, tricyclic antidepressants like amitriptyline, and narcotics or opioids, morphine, tramadol, methadone, fentanyl, and at last some anti-Parkinsonian drugs like the dopamine agonist. This is just I have picked a small number of drugs for you to remember, but there are a lot of other drugs also that cause delirium. So D stands for drugs and E for electrolyte imbalance, like hyponatremia, decreased levels of sodium in blood, or increased levels of calcium, hypercalcemia, can cause delirium. And L stands for low oxygen states. When there is hypoxia, what are the common conditions causing hypoxia? MI, myocardial infarction or heart attack, stroke, or a pulmonary embolism or embolism. And there are infections like meningitis or any infections can cause delirium. And R stands for reduced sensory inputs, visual and hearing. How can a person with a problem with vision or hearing develop delirium? How can they develop delirium? Any idea? Any guesses? If you want, you can unmute and talk, or you can use the chat box. How a person having reduced sensory stimuli or having a problem with vision or hearing problem, how can they develop delirium? Okay, I'll give a scenario. Think of a patient getting admitted in an ICU.
Sir, there is one comment. His body imbalances.
Okay, good. How that imbalances occur? Think of a patient getting admitted in an ICU. Is there any will the is the ICU an open area, or will there be a windows? Whatever I have seen around 8 to 10 ICUs in my practice in the last 6 years, and in most of the places it will be a closed area, so that infections and all doesn't occur. There will be air conditioning, everything. So a patient getting admitted in an ICU will not recognize when is day and when is night. Inside an ICU, the lights will be always on. Am I right? There will be a lot of beeping sounds from the machine. So the person doesn't know when is day. He's not seeing the sunrise. He's not seeing sunset. So he doesn't know when is day and when is night. So a similar situation can occur for an elderly person who has vision problem if he is not having his spectacles. Think of our own grandfathers or grandpa or grandma. If they have a vision problem and due to their medical problems or issues, they are not able to move out of their bed. Think of such a situation. If the windows are shut, how will they know when is day and when is night? Same thing applies to our hearing also. So reducing the sensory inputs is a key factor for developing delirium. Next, intracranial pathologies like CVA, cerebrovascular accident, stroke, or subdural hemorrhage or hematoma. And uncontrolled symptoms. When there is constipation, which is not getting relieved, when there is urine retention, or when there is uncontrolled pain, they tend to develop delirium. And there are certain metabolic factors also like hypoglycemia, hepatic or uremic encephalopathy, and certain acid-base disturbances. So just remember, when there is a sudden stress to our body or a patient's body, the stress can be anything. It can be drugs, it can be electrolyte imbalance. The above mentioned things are the stresses. So when there is a sudden stress to our body or our patient's body, they can develop delirium. So we covered this slide. And delirium threshold is lowered in below mentioned population or who are more prone to develop delirium. People in the extremes of age, elderly population, and patients who already has dementia, memory problem, they can develop delirium faster. And like I mentioned before, patients having hearing or visual impairment. So these are the, and I can't move my slide. Yeah. And delirium threshold is also lowered in people who abuse alcohol, alcoholics, those who are in a depressive state, those who are suffering from depression, those with reduced physical activity, and at last, those who are having a previous history of delirium. Now coming to the triggering factors. So till now, we discussed the definition for delirium, how to define delirium, how common is delirium, what are the causes for delirium, and who are the prone population to develop delirium. Now we are discussing the triggering factors for delirium. Should I slow down a little bit, or can I move faster, or is it okay? Are you all with me?
It's okay.
Yes, sir. Yes, ma'am. Yes, sir.
Okay, thank you. So coming to the triggering factors for delirium. Just a moment. A change in environment. Does a change in environment cause delirium? What are your thoughts? I mentioned about an elderly patient. Or think of our own grandfather or grandma confined to a room. They might be, it is their habit to use their own washroom. So even if their vision is affected or they have a hearing problem, at least they know where to find the washroom. So they can survive in their own house. What will happen when you suddenly change their room, or you moved out of the town and you found a new place to live, and because of love you took your own grandma or grandfather to your place? So what happens then? Because of your love you took them there, but for your grandpa or grandma, that is a new environment. It will be difficult for them to find the washroom. It will be difficult for them to find the kitchen. So their entire life, the balance in their life will get lost. So remember, even a small change in their environment can trigger delirium. Next point, an unfamiliar excessive stimuli. Too hot condition or cold condition or wet sheets. Think of the same elderly patient that I just now talked. Suppose they have incontinence, bladder incontinence. They are not on catheter. So once in a while, they'll pass urine in the bed itself. Is it comfortable to lie in such a position, lie down in such a position? Never. So if they have to lie down on wet sheets for a long time, that itself can trigger delirium and a general deterioration in the person's health due to multiple can be due to multiple like cancer or infection or whatever it is. And when there are uncontrolled symptoms that I mentioned before, pain, fecal impaction, urine retention, infection, etc., etc. This can also occur due to a primary or secondary brain tumors. I told that delirium is actually a cerebral dysfunction, something wrong with the brain. So if there is a brain tumor itself, and there is a tumor in the brain itself, that can cause delirium. And paraneoplastic syndromes can cause delirium, and biochemical disturbance we discussed, and drug induced, that also we discussed in previous slides. Now, withdrawal states, alcohol withdrawal, nicotine withdrawal, and those who were previously on psychotropic drugs. When you suddenly stop alcohol, when you suddenly stop that cigarette smoking, or when you suddenly stop the psychotropic drugs, they can develop withdrawal symptoms, and delirium is one among the withdrawal symptoms. And this also can occur in organ impairment, hepatic, renal, or respiratory problems. When sleep is deprived, sleep deprivation can also trigger delirium. And a surgery or a trauma or accident, a road traffic accident, can also cause delirium. How does it manifest? What are the symptoms for delirium? There are prodromal symptoms, like before the onset of the actual thing, there are some certain signs that tell you he's going into delirium, such as restlessness, irritability, sleep disturbance, especially at night, and altered sleep-wake cycle. That is, person sleeping more in the morning hours and less in the night hours. So coming to the actual features of delirium, and the above mentioned, previously mentioned the symptoms has a fluctuating course, which means it is not a stable intensity. At times it will be more, at times it will be less. Mostly the symptoms will be more in the evening hours. So this is called as a sundown phenomena. When the sun goes down, the symptoms increase. And attention deficit. This is actually the hallmark feature to diagnose delirium. Reduce attention span, shift of attention to new stimuli. What about their thinking capacity? Disorganized thinking. They have irrelevant speech. The psychomotor activity can be increased or decreased. They may attempt to escape from the bed. They may try to remove the cannula. They may try to pull out the Foley's catheter. And certain affective symptoms can also be there, like emotional instability, sadness, anger, fear, without any particular reasons. Agitation can also occur. And at last, altered perceptions, like hallucinations, can also occur. So in this slide, I have actually summarized the symptoms into core symptoms and the non-core symptoms. And I have mentioned how prevalent each symptom is. So you can also go through this later. It's the same thing that we discussed. Coming into types of delirium, there are actually three types. One is hyperactive, next is hypoactive, and in between, there's a mixed variety. As the name suggests, what is hyperactive delirium? There will be intense agitation. The patient will be restless. He'll be angry. He'll be shouting. The patient may be look paranoid. What about hypoactive delirium? He'll be calm, quiet, lying down mostly. He'll be withdrawn from the surrounding. He doesn't care what is happening around. And when symptoms of both this come together, it's called as a mixed variety. And I have a question for you. Out of these three types of delirium, which type of delirium is difficult to diagnose? Which type of delirium is difficult to diagnose?
The mixed delirium.
Why did you say it is mixed delirium?
Mm, because
See, I'll explain once more. In hyperactive delirium, the patient will be restless, agitated, paranoid, fearful. So you can see that the patient is exhibiting something. So you can understand that he is. In mixed variety also, at times he gets agitated. But think of hypoactive delirium. He's always lying down, withdrawn from the surrounding. What do you think? We'll always think that this is due to general deterioration. We'll think that the primary illness have flared up, have increased, and he is slowly dying. So this delirium will never come to our mind. So out of these three, hyperactive delirium is actually difficult to recognize and diagnose. Okay, am I clear?
Sir, here on mode. I think some technical issues is going on.
Are you all with me?
Yes, sir.
Am I audible? Are you all with me?
Yes, sir.
So something went wrong. So I'll share. I think I need to share my slide once more.
Yes, sir.
Is it okay right now?
Yes, sir.
Yes, sir.
So I don't know till what part you listened. So we are actually discussing which type of delirium was difficult to diagnose.
I
And
think, sir, hypoactive delirium is
yeah,
quite difficult to.
exactly. Hypoactive delirium is very difficult to diagnose. Why? Because there is nothing you can notice in a patient having hypoactive delirium. If it is hyperactive, there will be restlessness, there will be agitation, and the patient, there is something so that you can see. Whereas in hypoactive, the patient will be lethargic, withdrawn, calm, and quiet. What will you think when you see such a patient? We'll always think that this is due to the primary illness. The primary infection might have increased. It might have flared up. The patient, because of that, because of the infection or the cancer or whatever it is, the patient is weak. So we'll never think of hypoactive delirium in such cases. So coming to next slide. So this we explained what is hyperactive delirium. Hyperactive delirium. So the second point we'll discuss, this hyperactive delirium is more associated with drug intoxication, alcohol or drug withdrawal. Whereas in hypoactive delirium, this is more associated with hypoxia. The third point is more associated with hypoxia, metabolic disturbances, or encephalopathy. And hypoactive delirium patients have a higher risk of death. Okay, so the impact of delirium. What will happen if a patient develops delirium? There will be functional decline. There can be more incidents of falls. When falls occurs, fractures can occur. What will happen when fractures occur? What will we advise our patient? Immobilization. A patient having a fracture in the lower limb, think of femur, neck of femur, will put a cast and immobilize the patient. We'll tell the patient that not to walk or not to strain the lower limb. So he or she have to lie down in the bed for months maybe. So when you immobilize the patient, what will happen? Muscle wasting. There will be further decline in their general condition. So this is actually a vicious cycle. One thing will lead to another, will cause further decline. So there can be incontinence because of delirium, bowel or bladder incontinence. A patient having delirium, will he eat or drink on time? No. There will be problems with hydration and nutrition. And this everything will be a huge burden for the caregivers. Now, how to assess delirium? We understood how to diagnose delirium, everything and all we discussed. So there are certain standardized tools to assess delirium. There are multiple, like confusion assessment method, intensive care, delirium screening checklist, multiple tools are there. Out of that, confusion assessment method is widely used, and I have shared this here. It's actually very simple. You can download this from the Google and keep it in your mobile. So it'll be very easy for you. And the criteria to diagnose delirium is that there are four features: A, B, C, and D. Out of that, A and B should be always present. Always A and B should be there. And either C or D should be there. Okay. What is A? A stands for acute onset. The symptom should be acute onset and should have a fluctuating course. And to the right side, there are some questions to help you to get into the point. And what is B? Inattention, lack of attention. Does the patient have difficulty focusing attention? Does the patient become easily distracted? Does the patient have difficulty keeping track of what is said? So check if they have A and B. And what is C and D? Disorganized thinking and altered level of consciousness. So if you keep this in your mobile or whatever, you can take a printout and stick it in your nursing counter or nearby place. It will be very easy for you. And there are certain other conditions that mimics delirium, like dementia, depression, or even psychosis. So in left-hand side, I have the symptoms are mentioned. And see, acute change in mental status is present in delirium. This is also present in psychosis. See, whereas in dementia and depression, this is not acute. They are chronic conditions. See, inattention, lack of attention. This is present in almost all the things. Altered consciousness. See, altered consciousness is seen only in delirium. Whereas patient having dementia, depression, or psychosis, altered consciousness is not there. So this checklist will help you to diagnose delirium better. Now, in a clinical setting, how can we examine or what to do? History taking is very important. Write down the symptoms in chronological order. Okay, suppose the caregiver tell that he was normal since 3 days back, but 3 days back he developed incoherent speech. He's not recognizing me. He's not recognizing his daughter itself. Write down. Check if the symptoms developed acutely. Check for any signs of infection. Ask if he is taking any medicines. Ask if he is on any opioids. So take a detailed history. A detailed history will provide the diagnosis and the cause for the diagnosis. Okay. Then coming to the examination part. Conduct a head-to-toe examination. This is very important. Why? Because I told you delirium can occur due to many reasons. And this physical examination is very much required to identify the reason for delirium. In head, what and all can you check? Check for any signs of injury, any trauma, any contusion, any lacerated wound or something. Check for any bleeding from nose, ears. Check for any sign, any infected in the other parts of the body also. Check for any infected wound, bed sores. I told you, infections can cause delirium. So have a detailed physical examination. Assess the patient's hydration and nutrition and check for evidence of sepsis. And is blood investigations required to diagnose delirium? No, never. Blood investigations are never required to diagnose delirium. But if you do certain blood investigations, we can identify the cause for delirium. Okay. So like blood tests like CBC, total count, differential count are helpful to rule out infection. You can see whether the patient is having some infections. By checking electrolytes, we can see that if the patient is having hyponatremia, hypercalcemia. And by checking RFT or LFT, we can see if the patient is going into uremic or encephalopathy. So it helps to find the cause of delirium. Okay. Now, coming to the last part, management for delirium. So these points are not only for delirium, it can be for any diseases or any problems. When there is a correctable cause, correct it. And give emphasis on non-pharmacological management. And if there is no use with the above things, you can go for pharmacological or drugs. Okay. What is correct the correctable in case of delirium? If there is fecal impaction, what can you do? You can give laxatives or do a rectal examination and see the consistency of the stools and see if suppository or enema, whatever is the best option. So treat fecal impaction. If there is pain, give painkillers, analgesics. You can use the WHO pain ladder. If there is a small pain or if it is a light pain, you can give like NSAIDs. If it is a moderate pain, you can give mild opioids like tramadol. If it is a severe pain, if the patient is in severe pain, you can give a morphine or the strong opioids, morphine or fentanyl. And how to treat urinary retention? You can insert a catheter, simply. You can insert a catheter. If it is due to urine retention occurs due to an infection, treat with the infection with antibiotics. And dehydration. Dehydration can cause electrolyte imbalance. So give fluids and discontinue or alter drug dosage. You found that the patient is on morphine or opioids, strong opioids. And you also know that delirium is a complication when a person uses strong opioids in higher doses. So if you know that this so and so drug is causing delirium, try to reduce the dose or switch to a new drug if possible. Okay. Coming to non-pharmacological management, like optimizing sleep-wake pattern, patient orientation. We'll come into everything in detail. Optimize sleep-wake pattern. How can we optimize sleep-wake pattern? What can you do? What can you do to optimize sleep-wake pattern? Can I get some response in the chat box? As a nurse or healthcare professional, what can you do in your hospital setting or clinic setting or a palliative hospice setting so that the patient can sleep comfortably? What are the things that you can do?
So noise-free area and switching off the lights
Okay,
and dim lights.
okay, exactly. So this slide doesn't need any more explanations. We all love to sleep in a dark place. It is very difficult to sleep in a very bright area, right? So we can dim the lights at night. We can keep the noise levels low. I like to share one personal experience that I had in an ICU. I'm not telling in which hospital that was. I was a doctor there. I saw my patients, prescribed the required drugs. After my rounds in the ICU, I had friends who are nurses, and there were respiratory therapists. So there is a count of nurses and respiratory therapists or anesthesia technicians. And after the rounds, I'll go there, have some chit chat. But at that time, I never wondered that talking itself will be a disturbance for the patient. Have you ever wondered such a situation? I'm sure at least some among you might have encountered, would have been doing such things. that itself will be a disturbance for the patient. And especially in an ICU, there are multiple apparatus, multiple machines producing sounds, beeping sounds. There are certain things that we cannot avoid. That itself is causing a disturbance. So reduce the noise levels if possible and maintain sleep protocols. Like a gentle massage at the night time. Some people, they have a habit. Before going into bed, they'll drink a glass of milk. They might have practiced this from the childhood. So if such things can be entertained even in the elderly, that will help them. So when you train them like that, when you give a glass of milk at the night hours, their brain knows that it is time to go to sleep. It's time to shut down for a while. So maintaining sleep protocols can also help them. Yeah. Coming to next slide, patient orientation. You know that a patient having delirium will not be oriented to time, place, or person. So what can you do? Repeatedly reorient the person. Repeatedly tell them where they are, who you are, what you are doing. Tell them, I am Dr. Tony, I am Sister Lisa. I'm here to help you. I'm here to take care of you. Don't worry, Acha or Amma. Tell them you are currently, because of this, your infection or because of this cancer, because of your pain, you are admitted in an ICU right now. And some medicines, we are giving some medicines to treat your infections. Once this is settled, we'll soon shift you out. Explain everything. So explain where they are, who you are, and what you are doing. You can keep a white board also and write the important matters for them. You can write their name and keep so that the patient can see. Oh, my name is this thing. My name is Virendra. My name is so and so X and Y. You can write down the relevant informations and keep it in a whiteboard so that the patient can see. You can keep a clock also, clock and calendar. How many hospitals have a visible clock or calendar for each patient? It's very rare. There will be a clock or calendar at the end of the ward or general ward. I love to share one more experience. We all love shopping, am I right? And in this era, there are multiple shopping complexes like Lulu, Forum Mall, PVR. Many shopping complexes are there, shopping malls. So once you enter inside a shopping complex, there won't be a clock. There won't be windows. Why? It's actually a marketing technique. See, suppose you went inside to get 1 kg rice in a shopping complex. In the first section that you saw, there were chocolates. You need to walk to the next section. You found what meat items or other groceries like vegetables or something. Okay, next section also you went. Even if you don't want such items, you'll stay there because there's you're not sure that the time is passing by. You went on and on and on and on. And at last you found your rice and came out. At last, after coming out, you'll see, check your own watch itself. Oh, I spent around 3 hours inside. So this is the case of a healthy individual like me or you, everyone. But what happens to a patient admitted in a hospital or ICU? He doesn't know when is day, when is night. He doesn't know what time it is. He doesn't know what day it is. So try to keep a clock or a calendar for each patient. And this actually, and I know you might have watched this movie. What is this actor trying to do in this movie? Due to a trauma, this patient developed memory issues and he doesn't remember everything. So what is he trying to do? Trying to remember things. He tattooed everything in his body and will go and stand in front of a mirror so that he can recollect everything. So I'm not saying that you need to tattoo your patients, but uh, repeatedly reorienting the patient helps a lot in delirium. Okay. Having good communication and good sensory stimulation. As I mentioned before, provide eyeglasses if required. Hearing aids are also required if the patient has hearing problems. Provide dentures. When we admit a patient in an ICU, what? We'll remove the glasses, hearing aids, and give to the caregivers waiting outside. What for? Without eyeglass, he can't see properly. Without hearing aid, he can't communicate properly. So this itself can cause delirium. So try providing if possible. Encourage mobility. Mobilize as much as possible. Make the patient sit out of bed at least for the meals. And if you find that the patient is having delirium, try to avoid physical restraints. Do we like our hands to be tied? Will we be comfortable if someone put a handcuff for us? No, never. Similar thing applies to our patients also. They may be causing trouble. They may be causing disturbance in the nearby patient. So, if possible, avoid physical restraints or handcuffs. You can give sedatives. The patient will sleep comfortably. You can use that. Physical restraints are always inhumane for our patients. What will happen to the dignity of the patient? So think of that. I'm not saying that you should never use physical restraints. If the patient is causing harm to the patients around or to the healthcare providers or to patient himself, at times physical restraints are required, but try avoiding as much as possible. And minimize the use of catheters. Why minimize the use of catheters? An elderly patient
To avoid
who use,
infections.
okay, that is one point. The other one, other reasons.
He may pull it or do injury to it, sir.
Okay, that is there. That is there. But think of a normal person. What will happen if you put catheter unnecessarily? Think of an elderly patient. Previously, before putting catheter, at least he'll go to the washroom with some assistance. And since the caregiver was busy doing his personal work, the caregiver feels it difficult to take the patient to the washroom. He'll request the doctor or the nurse to put a catheter. And what will happen to the patient? The patient becomes lazy. The mobility decreases. And same story, worsening of the general condition. So infections can occur, like you mentioned, infections can occur. So unless it is necessary, minimize the use of catheter and monitor bowel and bladder function. Assess for urinary retention, constipation, fecal impaction. If you find any, treat it. Providing support and education. Involve the patient's family, involve the caregivers in all the decision-making progress. Educate them. Tell them that this is not madness. This is an acute phenomenon. This delirium occurred because he was on morphine, high dose of morphine. Now we have reduced the dose of morphine. He'll come to normal in a couple of days. So tell them, take the caregivers along with you. Ask them to reassure the patients in a calm voice. Okay. Now, the above mentioned, previously mentioned, all things have failed and still the patient is in delirium, then we go for pharmacological management. Okay, we use drugs to treat delirium basically to target two symptoms. One is perceptual disturbances, hallucinations, and all. And the next one is agitation. So, antipsychotics are the drug of choice, and in antipsychotics, haloperidol is the most commonly used drug for treating delirium. When you use a drug to treat delirium, always start with the lowest possible dose and slowly increase depending on the response. Okay. Considering haloperidol can start with around 0.5 to 2 milligram in every 2 hours or 2 to 12 hours. This haloperidol can be given orally through subcutaneous route or through IV route. But in an elderly patient, slightly reduce the dose, like a 0.25 to 0.5 milligram. And the maximum dose of haloperidol in a day in 24 hours should not exceed 20 milligram. And when you give haloperidol, check for extrapyramidal symptoms, especially when you need to give multiple doses of haloperidol. What are extrapyramidal symptoms? You can Google and see. The common extrapyramidal symptoms are tremors, etc., etc. You can Google that and see. Okay, that's beyond the scope of this class. And the next drug is quetiapine. You can start with around 12.5 milligram. You can go up to around 100 milligram. This can be given in every 12 to 24 hours. So quetiapine is available mostly orally, and the quetiapine has a stronger sedating effect. So this can help in patients having insomnia also. So this is a list of drugs and their side effects. You can have a detailed knowledge about this. And this also is the same thing. See, haloperidol. Consider the first drug, haloperidol. Sedation is less. But see, extrapyramidal side effects are very much more. More extrapyramidal symptoms are there. Whereas when you take the case of quetiapine, sedation is more, but extrapyramidal side effects are very less. So, depending on the case to case, you can select the drugs. And now next, sedatives or benzodiazepines. So benzodiazepines are only used for hyperactive delirium when the patient is agitated or restless. And here the most commonly used drug is midazolam, short acting. Can give around 1 to 2 milligram in every 2 hours. This can be given subcutaneously or through IV route. And the maximum dose of midazolam should not exceed 30 milligrams in 24 hours. You can also consider lorazepam, like 0.5 to 1 milligram. Okay. So I think we can conclude the session. Always correct the correctable. If there is a correctable cause, correct it. And give importance for non-pharmacological management. And a multidisciplinary approach is always required. Doctors are required, nurses are required, psychologists are required, sometimes psychiatrists are required. Communicate, always communicate and take the caregivers along and identify hyperactive delirium and treat it. So this is just an image to highlight all the important points. You can also go through this later. Now, any doubts or questions? If not, I have some questions for you.
Dear participants, ask any questions. Sir is with us. Sir, better to call someone's name and you can ask questions.
That will be very rude. If it is in a school setting, I would have done that. But
Yeah.
we are all are grown up adults. So
Yes, sir.
Uh, then I'll share one more thing.
Okay.
Can anyone of you please volunteer and read this?
Mr. R is a 68-year-old man with advanced pancreatic cancer, admitted to the palliative care unit for pain and nutrition support. He has a history of hypertension and mild dementia.
Hmm.
Continue, करूँ sir?
Yeah, continue.
On day 3 of admission, the nursing staff notices he appears more withdrawn than usual. He does not engage in conversation, sleeps through most of the day,
Hmm.
eats and drink very little. He mumbles occasionally and seems to be talking to someone not in the room. There is no fever, vitals are stable, and his medications include morphine, amlodipine, and lactulose. His daughter reports he was fine 2 days ago, chatting with us. Now he barely recognizes me.
So, what is the diagnosis here?
Hypodelirium, sir.
I'm sorry, I didn't get you.
Hypoactive delirium.
Yeah, exactly. In this situation, what are the causes for this hypoactive delirium? What can be the causes? What can be the probable causes for a hypoactive delirium in this situation?
Sir, I think pain.
If there is uncontrolled pain, okay, but he's on morphine, so we can suppose
Dose of
the
morphine.
pain is controlled. Can the morphine cause delirium?
Yes, sir. Maybe his dose need to be reduced
Yes,
or
exactly. So one thing is morphine, and what else can you see?
He sleeps throughout the day.
Altered sleep-wake cycle that can cause delirium. What else? Already he got admitted for nutritional support. Am I right? He was not eating or drinking properly. What happens in such situations? Electrolyte imbalance, hyponatremia can occur. So think like that. Okay, you can now you understood how to diagnose delirium, but try to find the causes for delirium also, so that it becomes very easy to treat. So is it clear? Any doubts? Any doubts, or can we conclude? So thank you, everyone.
So, sir, everyone are saying thank you. Thank you, sir. Thank you for the insightful session. It's very informative. And thank you, sir. And we
Okay.
can wrap it up for today. And dear participant, kindly share your feedback. I'll share the link on group. So, see you on the next session. And we have only 4 sessions more. So, kindly share your feedbacks. Thank you. You can leave now. Thank you, sir.